What is the pathology in the newborn baby? Identify the image. Image will tell you the pathology. Like you can see there is a coin which has been put over here. The baby is not straight. Okay, the baby is not straight. The baby is in a lateral position with a coin somewhere at his buttocks. This is a invertogram X-ray. Okay, it is a invertogram X-ray, which is done for anorectal malformations, where a child who has an absent anal opening, after 12 to 24 hours, you put a coin at the anal opening where it should be, turn the baby and take an X-ray. It's not for diagnosing ARM. You just want to see how far is the gas from this coin, the distance. If the gap is small, less than 2.5 centimeters, the ARM is a low ARM. It's a low defect. If the gap is more than 2.5 centimeters on X-ray, it's a high anorectal malformation. Okay, so this is an invertogram. वो measure करके पता चलेगा. They give a scale on the X-ray to tell you how far it is. It looks like a high ARM. To me, it looks like a high ARM. Once attendant. Okay. What is the diagnosis? Very important general surgery topic. What is the diagnosis? Coin का size भी compare कर सकते हो. इतना नहीं, इतना मत करो यार. इतनी comparison मत करो. इससे अच्छा CT scan कर लो. ये invertogram के बदले. So this is not a sebaceous cyst. Based on the typical location at the outer canthus of the eye, it's a dermoid cyst, and dermoid cyst should be excised. Okay, sebaceous cyst, where is it commonly seen? Where do you see sebaceous cyst? They are seen on the scalp, very common. Scalp or back. They have a black punctum. Dermoid cysts have a very typical location. They are seen near the eye. They are seen on the forehead, preauricular, postauricular. They are seen along lines of mesodermal fusion. Where the bones fuse, that's where you get dermoid cysts. They are seen at lines of fusion. So what's going to happen is, where the bones are fusing, the ectoderm gets stuck and it forms this cyst. This is congenital dermoid. Sebaceous epidermoid is the same, yes, correct. So simple, if it's a cyst, you will do excision. IND is for abscess. IND is not for cyst. Anywhere you see abscess, you do IND. Okay. Alright, pathology question more than surgery. Treatment of sebaceous cyst excision, but there you have to remove the punctum also. Size can increase. That's why they have to be removed. All are components of diabetic foot except angiopathy, neuropathy, sepsis are there. There is no venous thrombosis. Okay, there is no venous thrombosis. It's arterial thrombi. Okay, one of our favorite topics, mismatch in bones depth and associated appearance. Epidermal burns are red, dry, painful is correct. Superficial partial thickness show blistering, that is correct. They are pink and moist. Remember? Pink and moist. Deep partial are non-blanching. They show fixed staining and they show some deep sensation. Some sensation is present. So option C is wrong. Full thickness will show eschar formation. I feel there will be a question on this kind. This kind of a question will come in your exam. Something on depth of burns. Identify the depth of burn or identify the mismatch or some concept on the depth. Burn dressing according to degree. Yeah, for first and second degree, superficial, you just give a simple dressing. Okay, you just put gauze. For C and D, you must first put antimicrobial, then you can give whatever cover later. Okay. Blanching is seen in first degree and second degree superficial. Collagen is good for all. Yes, collagen is very good. But the problem with collagen, it's very expensive. You cannot use collagen over a large wound. So we use collagen over small wounds on the face. It's very expensive. Collagen is of course better. No doubt about it. But it's very expensive. So someone who has 30-40% burns, there you're not going to put कोलेजन, उसका एक एक दिन में 10-10 हजार खर्चा होगा, है ना. सो देयर यू पुट फर्स्ट कोट इट with some non-adhering like liquid paraffin like you guys are writing, or you can use bactigras. They are chemicals you put. Then you put gauze piece. And if it's deep burns, you put antimicrobial, then you put the gauze. Okay. So paraffin is just a coating. So this is first degree. This is superficial partial thickness. Second degree superficial. This is black and charred. That is third degree. Okay. When is sulfur sulfadiazine used? For second and third degree burns, you put SSD. First degree burns, you don't have to put anything because they are dry. Only epidermis is gone. What is the logic behind this question? What suture material is used for biliary anastomosis? What is the logic behind this question? Whenever you are doing any anastomosis, either biliary or urinary, you want to use a absorbable suture. Okay, you cannot use non-absorbable because that suture will form a stone. So if I'm doing any bladder surgery, biliary tract surgery, I have to use absorbable sutures. Only one absorbable here is PDS. Okay, it is PDS because I wanted you to think, is it monofilament, polyfilament, ऐसे करके. Then you would have thought like, oh, 3 monofilament, एक polyfilament, let's do more silk. Maybe if you knew so much. Or you would have been like, sir, कुछ idea ही नहीं है, तुक्का मार दो. ऐसे क्वेश्चन तुक्के नहीं मारने चाहिए, है ना. ऐसे क्वेश्चन तुक्के नहीं मारने चाहिए. These are standard questions. So you will use absorbable on biliary tract, absorbable on bladder, urinary tract. Nylon is normally used for skin or fascia or sheath. PDS is used everywhere. Biliary, even bowel surgeries, you use PDS. Polypropylene, you know, for vascular surgeries, for your mesh fixation. Morsilk आज के ज़माने में not very commonly used. Okay, Morsilk not so commonly used. It is used for superficial things like for drain fixation. ऐसे आपको पढ़ाएंगे, but really speaking, nobody really uses. Morsilk use very limited. Micral PDS both are fine. PDS is longer lasting, but both have their pros and cons. Rectus sheath, you use any non-absorbable suture. You can use nylon, you can use polypropylene, you can use PDS also, it's delayed absorbable. That's also fine. Vicryl you can use anywhere. That's why it's called workhorse suture. Vicryl is anywhere. What is the surgical position? This is called as prone jackknife position. Okay, the name of the position, it is prone jackknife position. Don't say for asphyxia. No. In surgery, where will you use this? It's a surgical position, na? Person is in OT, you've tied him. It is used for surgeries of this area. Basically used for perianal surgeries. Not very common. Normally for perianal surgeries, we use lithotomy. Aajkal. But you can use this. It will give you a good exposure for perianal surgeries. Okay, what is this position? Why I have 60%? Because they would have remembered it from my previous ENDs. क्योंकि उसमें मैं ये डालता हूँ फोटो. अभी मैंने फोटो चेंज कर दी यार, इसलिए लोगों को लगा रहे वही पुरानी फोटो चल रही है. So this is reverse Trendelenburg or head high position. Head low position will be Trendelenburg. फोटो कहाँ देखते हैं? पीपल थिंक सर सेम क्वेश्चन डालते हैं. मैं कुछ सेम नहीं डालता हूँ. मैं हमेशा 19-20 का चेंज करूंगा, लेकिन चेंज करूंगा. Because then people write on Telegram, what is the point of END and mini GT if questions are same? You know, they write. They don't realize I have had to record 5 NEET mocks, 2 INI mocks, 2 FMG mocks, plus mini GT, plus last week I went to Hyderabad, plus so many other million things I am doing. What is the point? That's what I write. Okay. What is this position? This is this is modified Durant position. This is for air embolism. Okay, person is having left lateral head low position. It is for air embolism. left lateral head low position. What is this condition? Please understand, this is umbilical cord. So the thing that you're seeing is below the umbilicus. Okay, infra-umbilical, there is a hole in the abdomen. This is ectopia vesicae or bladder extrophy. Ectopia vesicae or bladder extrophy. The treatment is asked, it is abdominal wall reconstruction. Okay, it is abdominal wall reconstruction. It has nothing to do with resection, anastomosis or anything. Huh? You have to do abdominal wall repair. Push everything back and repair it. Where is urachus opening here? No. There is no urachus opening here. There is a hole in the lower abdomen. Urachus was, if your abdominal wall, this is the umbilicus. This is the urinary bladder. In utero, your urinary bladder is connected to the umbilicus like this. That is urachus, which obliterates by the time you are born. It's called allantoin. Okay, it's called allantoin. Here there is a hole in the abdomen. This is the umbilicus. Uske niche there is a hole. I'll tell you, this is probably the bladder. Looks like the bladder. This look like the genitalia, which have protruded out. Okay, I can't make out whether it's a male or female child from this photo. It could be a underdeveloped penis in a male child. That's what it looks like. Okay, all this will have to be reconstructed. LATS procedure is done for a condition called as midgut volvulus. You know what is midgut malrotation? When the midgut does not twist normally, it does not reach the correct position. That is malrotation. That malrotated gut twists around itself. That is called midgut volvulus. Usme do LATS procedure. Okay. What is this condition? The first one. This one is where the intestines are bare. This is called gastroschisis. It is an isolated condition. And the other one is omphalocele, where you have covering of the bowel. Someone is asking, how do you correct the different things here? It requires 3 stages. Abdominal wall reconstruction is done at 6 weeks. Then at 6 months, you are going to do epispediasis repair. If it's a male child, he will have epispediasis. That will be repaired at 6 months. And whatever problems are there in the bladder, if at all, that will be done at 6 years. So bladder repair will be done at 6 years. That is the timing of repair. These conditions have to be repaired at birth or in the first few weeks. The problem is, if the hole is very big and so many things are out, how do you put it back at birth? You can't. So what do you have to do? Every few days under anesthesia, slowly you start putting the intestine inside over a period of time. And once it has gone inside, you stitch the abdominal hole. Okay, yeah, in the meanwhile, it requires a cover. You have to put a bagota bag. Yes, correct. You have to put a cover. Bagota bag has to be put in the interim. Absolutely right. Till you do the repair. All this is done in a neonatal ICU. This child will not be sent home. Obviously, he'll be in the NICU because he'll have other problems also. Like omphalocele will have cardiac anomalies. This is actually an anesthesia topic. I don't know if it's covered, but quite an easy thing. What is not a component of ERAS? What is ERAS? It will tell me how child will void. No. He will void, but there will be some problems in the bladder, like he will have a vesico-ureteric reflux. That reconstruction is done later. Okay, this is called enhanced recovery after surgery. It's more anesthesia than surgery, where you do some things pre-operatively, post-operatively, so that the patient has a good outcome. Like you have a good pain relief. Why you want a good pain relief? Multimodal analgesia. How it helps in outcome? Why pain relief? More the pain relief, lesser will be the inflammation. Okay, lesser will be the inflammation. Lesser will be the surgical stress. Faster will he start walking, faster he will start eating, faster will be the recovery. Normally, when you tell patient has to be starving, you keep them starving 6 hours, 8 hours, 10 hours. No. Now, give them carbohydrate loading or clear liquids up to 2 hours prior to surgery. Up to 2 hours. So he can have water with Glucon-D. So clear liquids up to 2 hours is permissible. Early ambulation as soon as possible. Like when I do bariatric surgery, I make my patients walk 5 to 6 hours post-op. Means the day they are operated, same evening they have to start walking. Within same day, so that they don't get DVT. IV fluid usage should be restricted, not aggressive. Why? Why restrict IV fluid use? It should be restricted, it should be judicious. Why should it be judicious? Carbohydrate loading means 2 hours before surgery, he has to have a Glucon-D. It is so that he doesn't get fluid overload. If you give too much IV fluid, he will have fluid overload, which can cause pulmonary edema, tissue edema, and that tissue edema will affect wound healing. So you don't give too much fluid, you give limited fluid. Okay, if you give limited fluid, you don't have to catheterize them. They will pass urine aram se. So their recovery is faster. So these are the ERAS protocols. Like preoperatively, optimize the patient. Intraoperatively, multimodal analgesia, limited fluids, avoid nausea, vomiting. Limited means depending on the weight of the patient and the requirement, how much fluid loss he is having during the surgery. Depends on the time of the surgery. Avoid putting drains tubes, prefer laparoscopic surgery. Laparoscopy is preferred. Right? And early nutrition. Same day you start giving them water. Early mobilization. Judicious post-op IV fluid use and discharge them early. Like I do surgeries in patients who are very high-fi, 5-6 hours off walking nahi. After 5-6 hours start walking. Post लिखा है ना, after. Like you will say ना, इतनी बड़ी surgery हुई और डॉक्टर बोल रहा है same day start walking. Patients don't agree. You still force them to walk. Not 6 hours off. Okay, 5-6 hours post. Right? Open surgery के बाद depends on how big the surgery was. If it's an open hernia repair, he can walk same day. Then he can walk same day. But if it's a laparotomy for some big cancer, then he won't walk. So you avoid doing all that. Yes, you give prophylaxis depending on the risk of the surgery. Okay, new concept. I don't think I've ever discussed this, but I'm sure you would have studied in ENT. That patient on high altitude has a swelling in front of the neck. It is a rubbery swelling and it is showing lateral mobility. It is a pulsatile swelling. What is the swelling? It's not a glomus tumor, it's a carotid body tumor, also called a chemodectoma. It is seen at the carotid bifurcation. It looks like this. At the bifurcation of the carotid, it arises from the carotid body. It is basically hyperplasia in the setting of a chronic hypoxia. Because he's in high altitude, because of hypoxia, that body undergoes a enlargement. It's called a chemodectoma. Because it's arising from the carotid body, do not do any FNAC or biopsy. Okay, do not do any FNAC or biopsy. That is contraindicated, especially since it is pulsatile. What is this phenomena? Swelling shows lateral mobility, but it does not move up and down. It moves laterally, but not up and down. It is called curtain sign of parotid. Here it is called Fontaine sign. Okay, here it is called Fontaine sign. In parotid, it is called curtain sign. Okay, this is called Fontaine sign. It moves laterally, but not up and down because it is stuck to the carotid artery. And the treatment, obviously, first you have to confirm you will do USG with a Doppler. And if you do a CCT angio, some of you are saying correctly, it shows what is called a Liar sign. Basically, the carotid artery gets splayed away. There is a splaying of the carotid artery by the tumor. The tumor pushes it laterally. The angle becomes broader. That is called Liar sign. splaying of the carotids. The treatment has to be resection. Problem is, if it is very close to the common carotid artery, you may have to do a common carotid artery reconstruction. Okay, so if it is invading the artery, if it's a malignant carotid body tumor, you'll have to do a carotid reconstruction. Fine, otherwise you can do a simple excision. What is incorrect about the condition of seen post-operatively? It's not a normal scar, it's a hypertrophic scar. Okay, it's not a keloid. Remember, keloid looks like cancer. This is not looking like cancer. It usually will subside in the first 3 months. Okay, it will usually subside in the first 3 months. All right. So hypertrophic scars will be seen early and slowly they will fade. A keloid will keep growing. They will keep growing. This will be limited within wound margins. Uniformly arranged collagen. What type of collagen is this? Uniformly arranged. What is the type of collagen? It is an immature collagen. Okay, so it will be type 3 collagen. Okay, uniformly arranged type 3 collagen. It occurs at site of skin tension like abdomen. Very common. Fine, so this is a hypertrophic scar. This is keloid. It contains type 3 collagen, but it is haphazard. Okay, it is a haphazard arrangement of a type 3 collagen. Disorganized. Yeah, sternal area, earlobes, seen in dark skinned individuals. Whenever I say dark skinned, you guys start using words you should not be using. Hypertrophic scar may reduce, it will not resolve, but it may reduce over time. Okay, it may reduce, it may fade off. Okay, say no to racism. Say no to racism. Which of these is not a high risk factor associated with refeeding syndrome? You know, I always say these kind of questions will come. Then they come in the exam, and then students don't even say, "Arey sir, aapne bola tha," hai na? But this came in the exam in INI-CET. They asked, what is the mechanism of refeeding? So, who is at risk of refeeding? Very low BMI, too much weight loss, long-standing malnutrition, or pre-existing hypophosphatemia. If there is already deficiencies, he will have the unmasking of those deficiencies faster. Okay, not a pre-existing hyperphosphatemia. Right? So, these are the risks of refeeding syndrome. Why does it happen? It's because of consumption of your phosphates and magnesium and calcium. Suddenly they get used up when the person is given feeding very fast. Fine? Cool. So, please give the mini GT. Okay, please give the mini GT. You get more 30 questions there of this kind only. Hopefully, you will say well framed, not very bad, not very tough. And I don't know if anybody got full marks, but at least if you got 60 plus, you're in a good space. If you are in the border, then you see what is your target. I always say do goal directed preparation. Target rank 5,000, 10,000, you should get more than 55. Target rank 20,000, more than 50. So target rank top 1,000, more than 60 is ideal. Right. So if you are getting that, then your surgery preparation is on track, because these questions were standard questions. They were not very tough, not very easy, in between, covering all the topics. I went from each and every system. And if you are making silly mistakes, it means you need a little more practice, right? So keep that in mind and keep your preparation last 30 days tuned to that. That mera target kya, what's my aim? And accordingly, you have to study the different subjects. I told you what is your state based on this in surgery. So, based on your preparation, think about what needs to be done. There is still enough time, good time to make things work. Okay, there is still good enough time. You can still make a lot of difference if you use your brains. All right, fine. So, in hypertrophic stenosis, the fluid of choice is ringer lactate. No, it is DNS with KCl, because he will have hypokalemia. Yeah, he'll have hypokalemia, so fluid will be DNS plus KCl. KCl has to be given. in hypokalemia. Okay, so I tried to do things fast at a decent pace so that you get most of the information and also you get enough time to do your revision. I didn't want to take this for 4 or 5 hours. So keep this in mind and keep your preparation going. And if you need any help, legitimate help, you can message me on Telegram. All right, cool. RL is also given in children. You don't prefer RL, you prefer DNS. You will always give dextrose containing fluids in children. You need any help, this is where you can get to me. But stay focused now, don't lose focus. Okay, take care guys, bye bye.